All right, still going?
Great. All right. Well, thanks everybody for joining us now that we've overcome our technological hurdle here. Um, I'm really pleased to present Dr. Justin Cirone, introduce him to us for our MTAC conference today. Dr. Cirone is, I guess, almost the newest member of our ACS division at Atrium. He's a New Jersey guy, but he's blending into the South just fine, having trained up at Dartmouth and then was at UT San Antonio for his fellowship. So his specialty obviously is trauma and critical care and emergency general surgery, and he's going to talk to us a little bit about that today. So Dr. Cirone, thanks for joining us, and look forward to your talk.
Great. Yeah. Well, thank you everybody for joining. I was asked to give a lecture on literally anything apparently related that the MTAC might be, the crowd might be interested in. And while I have a lot of interests, by far and away, my number one interest is optimizing care for trauma patients. One of the things that I've been very involved with in the recent past, has been teaching ATLS and teaching trauma to both providers from all over through ATLS, but then also with residents, med students, APPs, anybody who comes through the trauma bay at the various places that I've been at. And while I couldn't make it to the ATLS course today because I'm, clinical today, I wanted to at least put together something that is a little bit of a spin-off of ATLS. This is essentially almost like an expanded ATLS. I couldn't come up with a great creative name for it, but this is like the advanced trauma life support portion of the course, where it's not necessarily meant to be a lecture to teach people how to be a trauma surgeon per se. We're not going to go into a whole lot of operative stuff, but this is more so a lecture designed to summarize a lot of the things that we as trauma surgeons discuss in our free time when we're bored and just kind of chatting about whatever. And there are a lot of curiosities, a lot of things that we feel could potentially be optimized. And I won't get into too much detail without just getting started here. But the general gist of this is that there's a lot of interesting things that are happening out there in the world, and a lot of ways in which we can really optimize the care of trauma patients. I don't have any financial disclosures, the obligatory slide here. So topics very broadly that I'm going to discuss is essentially pre-hospital, trauma bay, and then a couple debated topics that, come up not infrequently at our trauma center, and I'm sure at other trauma centers. It's come up at one of the several I've worked in the last several years, and just kind of curiosities more than anything. Some of the information in this lecture will be more of, I don't want to say opinion, but it's not necessarily evidence-based, and I will point it out when it's not. But it's a lot of stuff that we like to discuss a lot, and I wanted to kind of put it out there to give everyone these talking points as well for the future, to help everyone stay informed as much as possible when talking about things that go beyond just the routine ABCs, so to speak. A lot of this, so I've been recently watching this show, and I'm not going to spoil anything, but there's this show out on FX called The Bear, which is fantastic. Based in Chicago, which is where I did my research and some trauma training, got a master's degree. And the concept is really fantastic about this like restaurant. It's kind of like a Chicago meat shop that then turns into like a fancy restaurant or something. I don't really know. I haven't seen all of it. But the part that I did see that I've loved so far is an episode about where they really harp on this idea that every second counts. And the concept is that with really fine dining or really finely executed anything, it really matters down to the second, what you're doing, when you're doing, how you're doing, and how to optimize every moment of your day. This concept will come up a lot, but I think in no other field potentially than trauma, when people are literally hemorrhaging and or herniating to death, does this concept become so ridiculously important that I'm going to really try to harp on this throughout this lecture. To emphasize the importance of time, this was a interesting study for two different reasons. So this is called Death by the Minute: Inequities in Trauma Care for Victims of Firearm Violence. I do a lot of work with firearm violence and have personal connection and do a lot of research with it. But this study was interesting for two reasons. One reason, it was basically pointing out that those of disadvantaged backgrounds, socioeconomic backgrounds, are at there's an inequity of their care because they literally take longer to get to the hospital and die. But what also stood out to me was that across the board, actually, there was a significant drop off of survival rate based on time to transport. And the time difference was 9.4 minutes and 10.5 minutes. So we're talking, 70 or 66 seconds worth of time. That was actually the cutoff that was statistically significant to determine who lives and who died. Now, there's the different interquartile ranges, and there's some overlap in those, of course, and variabilities with, different injury severity scores and such. But this is what we're talking about when we talk about the real trauma, not necessarily a fall from standing with a scrape on your elbow, but the bad trauma. We're talking about a matter of seconds will determine who lives and who dies. There have been places, and Charlotte is one of them, that have, acquired the practice of having the police personnel actually aid us in pre-hospital transport to varying degrees and to varying ways. But this study was pretty interesting in that, the police median transport time is actually significantly shorter than EMS. And that might make sense because the police get activated. There might be more of them out on the streets, ready kind of in the areas where they know trauma is more likely to happen, and they're more quickly able to pick up patients and bring them back to the hospital. However, you then lose the ability to have a paramedic in the back of the truck to put an IV in and to get other care started for the patient. So there's a trade-off to it. But they actually found that the pre-hospital transport time was significantly less. I mean, we're talking 11 minutes less. However, given the fact that you missed the pre-hospital paramedic care, the outcomes were more or less the same, with one exception, which was that the unexpected survivors. So these are people who, based on injury burden, they were not expected to survive. They were actually more likely to survive by the police being transported than the EMS. Now, there's speculation as to why that may be, but I would postulate that your group of the most likely group of unexpected survivors are going to be those with a devastating hemorrhagic injury that needs to be addressed and resuscitated as soon as possible. And for the amount of time it takes EMS to get to the patient, which in this study was 21 minutes, the police could have already had them in the trauma bay. And that, I think, is a group of patients that is pretty remarkable. The p-value on this technically wasn't significant, but when you look at the overall values, it's like 1.1% higher total absolute value, and like a, 4 or 5 times higher rate of survival under the unexpected survivors. Transport time to hospitals is an interesting thing. This here is a depiction, evidently from Europe, where it is law in this region to actually part ways on the highway so that emergency personnel can come down the middle of the highway during times of traffic. And this is something people get tickets for, and something their society has decided is something they want. So they actually part ways on the highway. That way EMS, fire, police can all get down the middle without any obstruction. I'm convinced if you did this, it would turn into what I usually see outside my window downtown, which is something like this. And people are going to fill in every single space a car can possibly go, no matter what. And this is unfortunately reality of what people in Charlotte, the paramedics and the police, deal with on a not infrequent basis. Again, we're coming down to this concept of every single second in a serious trauma counts in terms of trying to keep that individual alive. This here was shot by yours truly from my patio downtown or uptown, showing you literally what happens in the middle of the night in Charlotte at times. This is where you could potentially see that, there's cops apparently on their way based on all the sirens and, already got notified that they were alerted. But this is literally what happens on a not infrequent basis in town here. These individuals, if they were to get struck, obviously would need to be transported quickly, but you can see there's not actually a great way for paramedics to get in there right now because they intentionally blocked off the road for this, which obviously there's just so many reasons that this is a bad idea. But this is what happens every day out there and is what we deal with on a daily basis in trauma. So coming back to the idea of why trauma patients die, by far and away, it's hemorrhagic shock, and death from excessive blood loss. The one of the key things that ATLS teaches, and I think in the real world we probably don't do as much of, is ensuring that we get the fastest parenteral, like IV or IV equivalent access on patients to start that resuscitation process. And having parenteral access is great for things like pain medications or antibiotics, etc. But those aren't going to save someone's life during an acute trauma with hemorrhagic shock. I will not claim to be an expert at placing peripheral IVs. I can certainly do it, but gosh, every nurse in any trauma bay I've ever been in is about 1,000 times more skilled at this than I am. I also know that anytime people place IVs in trauma patients, their veins are often extraordinarily collapsed. It's one of the reasons at a place that I recently worked, one of the mantras was essentially if you couldn't get an IV on the first poke, you went to an IO. And we really pushed for the IOs to be placed because of their efficacy, because of how fast they can be placed, and because it freed up the paramedic either in the back of the truck or the nurse in the trauma bay to start doing other things, which is incredibly important when you start having even mini mass casualties. This here was a group looking at systematic review and meta-analysis of the efficacy of IO access for trauma resuscitation. So here you can see success rate on first attempt is like ridiculously in favor of IO. If anybody else has ever tried to place one versus an IV, it is like extraordinarily easy. As long as you know the landmarks, you just click a button, it goes in. It is incredible. I'm a huge fan of how quick it is. I'm going to show some other graphs, and just as a fair warning on this paper, I don't know why they did this, but they actually reversed it. So now IO is going to be favored on the left side of the screen. So on this graph, IO is now to the left. You can see that the mean procedure time ranges, and this is in minutes, somewhere between about 8 minutes to 3 minutes faster, 2 minutes faster. And all of the studies are just way, way further on that side. And again, when you're talking about seconds in resuscitation and seconds in terms of whether or not someone lives or dies, this is an incredible amount of time. I mean, I've spent less time in the trauma bay altogether with patients who have been dropped off in hemorrhagic shock, who get dropped off, leave the trauma bay and go to the operating room in less time than it takes to do this. And the mean time to resuscitation is still in favor of IO. It's a little bit less, and I have a suspicion as to why, but they don't really dive into that. After the IO goes in, you do have to flush out the marrow and you have to get the tubing, and there's often a little bit of confusion about how to do the dressing because some places have the actual formal IO dressing, others do not, etc. But either way, you're still talking a difference in terms of starting your resuscitation, which is huge in hemorrhagic shock. And then an intraosseous catheter is actually a central line, technically. And as you can probably imagine, the amount of time it takes to place a central line, on average, best case scenario, you're looking at like 5 minutes and upwards of 16 or 17 with an average in the range of about 7 to 12 minutes to place this line. That's more time than I usually even like to spend in the trauma bay to begin with. And the only benefit of that central venous catheter is slightly faster infusion. And it is faster, don't get me wrong. However, you could also just put in a second IO, or by that time, if you've gotten some volume in them, chances are you can get a 14 gauge catheter into the other side. And now you can be infusing 2 units of blood through 2 different access ports, which is going to equal or supersede some of the Cordis catheters that we use. This is probably old news to the majority of you, but again, just to kind of show you the value of interosseous lines, this is kind of the flow rate through different size catheters and different length catheters with Passot's law, meaning that the longer the tube, exponentially slower the flow rate is, and the wider the diameter of the tube, exponentially greater flow rate. So a 14 gauge short cannula is going to have a flow rate of about 236 milliliters a minute. With the pressure bag, everything is faster as could be expected. This now is an area of my personal interest that I often have not necessarily disagreements with, but I need to point out that it's really important that you recognize that if you put on something called a BioNectar or a Max Plus, it's that needleless connector. It's the little blue thing that I'll show in a second. If you put that on there, you've automatically dropped down your flow rate to at best maybe like, I don't know, an 18 gauge catheter. Even if you put in a 14, or even if you've got a Cordis in there, if you put that a needleless connector on it, that is a point of resistance, and that will significantly drop off the amount of volume you can infuse, regardless of how big the tube is, because you put that connector on there. And as you can imagine, with pressure, with pressure it goes up, and with the bionectar, they all go down to varying degrees. When you look at the interosseous lines, you got your two main options are tibial and humerus. I won't get into other ones because it's kind of outside the scope of routine care. There's a little box. I had a box on here. There we go. So when you look at the flow rate with a pressure bag, an interosseous, either humeral or tibial, is somewhere between an 18 gauge and a 14 gauge on a pressure bag with a liter cath. This is a pretty significant line. I mean, we're talking 200 or 150 cc's a minute on a pressure bag to be able to get into an individual. And my personal recommendation would be to significantly favor the humeral line than the tibial line, for several reasons. So when you look at trauma overall, we know that one of the contraindications to interosseous lines is a fracture in the ipsilateral, in that same extremity on the same side. So when you look at the rate of a pelvic fracture, hip fracture, femur fracture, tibia fracture, globally, it's about 67 million per year. And any of those would be a contraindication to put an IO into that tibia. Whereas if you combine humerus plus clavicle and scapula, and I don't really even need to include those because that doesn't entirely count, but it's the only way the Lancet article actually described them. You're still only talking about 19 million. So just purely based on numbers alone, you are far less likely to have a fracture in the same extremity that would preclude you from using the interosseous line as a humeral versus a tibial. The humeral also still has a pretty excellent flow rate up there, like I said, with the 16 gauge catheter. Additionally, some injuries such as this, you may not notice a fracture in the extremity. Technically, if you feel this person's hips, you should feel that they're unstable and put a binder on, but you may not if they're overweight, they're obese, or for whatever reason, maybe it's just not picked up. If you infuse into a tibial here, you could run into issues where the blood's not going to make it back. Or let's say you actually do get it in there and it perfuses into the saphenous vein and it actually starts making its way back up. It's just going to leak out into their preperitoneal space where they're bleeding from this fracture. This is another example of somebody who has an IVC injury, where again, if you perfuse below the diaphragm, it's not going to do anything other than fill their belly up with all the stuff you're giving them. And yet another example of like a gunshot wound that I saw, where they had put in a IO on this side, and I don't understand why. Thankfully, this guy only has a superficial wound and went home like 4 hours later. But again, the upper extremity, anything above the diaphragm in terms of access, is going to be superior in any trauma. This one, again, going back to this idea of the needleless connectors, this is that little blue thing I was talking about. Nowadays, the ones that we tend to use are these Max Plus connectors, needleless connectors. So you can see here, this study was looking at the flow rate of crystalloid, undiluted red blood cells, and they actually use diluted red blood cells, which I won't get into because it's not something we typically do in a trauma scenario. But when you connect the needleless connector, again, your flow rates are like cut in half or worse, depending on the viscosity of the fluid that you're giving. So I really cannot emphasize enough that from the nurses or the paramedics that are giving these things, to maintain that if you're trying to transfuse something quickly, you need to make sure that the tubing is as short as possible and that there is as few interruptions as possible along the way, especially something like a needleless connector. Again, every second counts when you're trying to infuse here. And if your infusion rate is half as quick, that could mean the difference between life and death, or it could mean the difference between the patient arriving with a pulse to the trauma center or arriving without a pulse. Another topic of pre-hospital interest is tourniquets. These are a fascinating part of medicine today, both excellent and amazing, and also in some ways a little bit some drawbacks to it as well. In fact, there were so many drawbacks to this that after World War II, from a historical purpose, tourniquets use fell out of favor. It was actually essentially taught to the military not to use tourniquets because of the number of people who were getting amputations due to tourniquets being left on too long. Now, granted, here in the greater Charlotte region, our transfer times are not usually more than 4 hours. Not usually. Um, and tourniquets are not typically left on longer than that. However, in any other environment and for all the places you all might work in the future or currently work, this might be more of a reality. Again, I trained in rural New Hampshire up in the Dartmouth region where like some of our transport times were hours and hours. And some of those times were hours just to get off of the ski slopes because they were off on some cross country trail and they used their satellite phone to call for help and they put their own tourniquet on appropriately. But by the time they got to us, they had to get an amputation. So in the Korean and Vietnam War, actually, these tourniquets were very seldom used. And because of that, even through, believe it or not, 2001, during the post 9/11 war efforts, tourniquets were still not used that often. And the majority of soldiers actually died of hemorrhage. This here is from the Tactical Combat Casualty Care book. And I am not military. I won't claim to know what it's like to be military, to go through this training, but I do know a lot of the phrases and words that come out of it, given the reality of being in the trauma world. So this here is just highlighting that the number one potentially survivable cause of death at the point of injury is hemorrhage from a compressible wound or any life-threatening extremity bleed. And more than 90% of 4,500 combat deaths after 9/11 died of hemorrhage-associated injuries. That number is strikingly different today, thankfully, but a lot has changed in the past, 24 years or so. Here is one of the things that I think we can do better pre-hospital. So this comes straight from the military handbook. The hasty application of a tourniquet is recommended during care under fire, and it should be placed over clothing high and tight. We are talking about a scenario in which you are in an open field and you are literally being fired upon, or you are in a situation where you do not have cover and you know you got hit or somebody you're with got hit. The concept is that you don't have time to look to see where the bullet went in, where it went out, how many times they were hit to go and put on this like nice, thoughtful tourniquet. You just need to make sure they don't die of hemorrhage before you can get them to a place where you can assess them. So you just put it as high as you can, as tight as you can, and that will stop the hemorrhage in the extremity. However, the next paragraph in this book, and this is unfortunately how people often come to us in the trauma bay, is they have a high and tight tourniquet with like a low calf penetrating wound or like a forearm penetrating wound, and the tourniquet is up in their armpit. And again, this teaching is correct if you're under fire. If you're not under fire, the next line says the deliberate, as in opposed to the hasty application, the deliberate application of a tourniquet is addressed when behind cover. So you're still in combat, but you now have cover. You now take the clothes off and you put that 2 to 3 inches above the wound wherever the wound is. This is from the military book from 2017. And this is what we can be doing here in all trauma scenarios pre-hospital. This was an excellent study by a lot of notable people, or this is really more of like an opinion paper, so to speak, but kind of rethinking the limb tourniquet conversion in the pre-hospital environment, and something that I would encourage us to really advocate for. They quote, and this is true, the tourniquet conversion, meaning taking the tourniquet off and doing something else, is attempting to convert a tourniquet to a hemostatic pressure bandage as soon as possible. Remember, with enough pressure, all bleeding will stop. The question is whether or not you can stand there and hold the pressure manually and or get a dressing on tight enough that stops it on its own. If you can get a pressure dressing on a wound, then around the wound, you will still get perfusion to your distal extremity, and maybe it's a venous injury that will stop with pressure dressing, and you no longer risk ischemia of the limb and all of its associated morbidity. This year they put together, I thought it was fantastic. Again, going off of and working with the Joint Trauma System for the Tactical Combat Casualty Care, myths and facts. All tourniquets should be applied high and tight is a myth. Once a tourniquet is applied, leave it alone is a myth. And tourniquets can only be removed or converted by a surgeon, which is absolutely a myth. They go down the facts here of high and tight were only for care under fire. So if you are literally under fire in the greater Charlotte region, you can do high and tight. But the second you get into the back of a police cruiser or into an ambulance or you have cover, then you change your tourniquet. Previously applied tourniquets should be reassessed for control of bleeding and proper placement. And tourniquets should be reassessed and either properly applied on the limb or converted to a pressure bandage by anyone trained to do so. Essentially, if you know how to put a tourniquet on, you can take one off, and you should feel empowered to take one off. If you take the tourniquet off and it is positioned in the right place, and you notice that there is an indication for a tourniquet to be in place because it is bleeding through a pressure dressing, you can put the tourniquet back on. And you've now potentially saved that person a great deal of morbidity from an incorrectly placed tourniquet. Along these same lines, talking about the whole pre-hospital course here, had the pleasure of working with Don Jenkins, who's still down in San Antonio, fantastic trauma surgeon, military, who is an advocate of whole blood resuscitation, with this excellent quote here that, if you bleed whole blood, give them whole blood. Um, we in the San Antonio system have one of, if not the most robust whole blood transfusion systems, although a lot of cities are now catching up and or certainly on par, if not maybe exceeding what they're doing there, but it is quite impressive. I wanted to touch base on this a little bit because I know there's a lot of pre-hospital personnel involved at MTAC. And the reality is that if you're not a pre-hospital individual involved in the care of the trauma patient, I promise you that patient's coming to you anyway, so that once their pre-hospital course is done, they're going to be intra-hospital course. And that's when you take over, and you want that pre-hospital course to be as optimized as possible. So we used to talk about crystalloid and how much to give, and I put this bag of Plasmolite up for other reasons, particularly because San Antonio preferred Plasmolite over LR or NS. But the ATLS 9th edition, which came out several years ago now, said 2 liters of crystalloid should be administered when somebody comes in some kind of hemorrhagic shock. Then the 10th edition came out and said, actually, it's probably more like 1 liter of crystalloid. And then they also had a caveat where they mentioned that there was great studies showing that more than 1.5 liters of crystalloid infusion independently increases odds of death. In our pre-hospital setting here in the Charlotte region, our transport times are typically so fast that this isn't an issue. But in more austere environments, this might actually become an issue as pre-hospital personnel see, oh, the blood pressure is dropping, give another 500, give another liter. This is actually going to make them worse. You make the number better, you love seeing that number go up, but you're actually ruining all of their coagulation cascades. And the current therapy of trauma and surgical critical care notes that rapid resuscitation can exacerbate bleeding by dislodging fragile clots, decreasing blood viscosity, creating compartment syndromes of the cranial vault, meaning like herniating, but also the abdomen extremities. And it exacerbates the lethal triad of hypothermia, acidosis, and coagulopathy because the most commonly transfused crystalloid pre-hospital is normal saline, which is significantly acidotic. It is often cold. Even if you warm the crystalloid, you actually still have to put it through a tube, and that tubing is not usually warmed at some point, and it cools off quickly. It's just like blowing on a spoon with soup on it. It cools off relatively fast. And this crystalloid does nothing but dilute all of your coagulation factors, which makes you more coagulopathic. Crystalloid's not the enemy, and a lot of trauma patients come in hypovolemic because, for example, they were drinking a lot and they urinated a lot from the diuretic effect of that alcohol, but it needs to be taken into context with whether or not the patient is hypovolemic from volume down or if they are hemorrhagic or if they're hypovolemic from hemorrhage. This was an example of what a different trauma system, and I know every system is set up differently, but this was actually a pre-hospital criteria for the paramedics to give whole blood without ever checking with a provider. They didn't have to call into the trauma bay. They didn't have to call me because I was the only provider in the trauma bay. We didn't have anyone else that would have answered those calls, maybe my team. But if any of these either one of these were present in penetrating trauma or 2 present in blunt trauma, pre-hospital ground and air paramedics had at least 1, if not usually 2 units of that's low titer O positive whole blood. And they were allowed to give that pre-hospital. As soon as they did it, then activated our highest level criteria, et cetera, et cetera. But having that blood running on arrival makes all the world of difference. And we do have that here in the greater Charlotte region for some of our pre-hospital personnel, but my understanding is that we don't have it for all of them yet. And it's certainly something we could consider expanding into the future, although the logistics behind that are way above my pay grade, and I don't want to pretend like that's something easy where I can just put an order into Epic and it'll happen. So one of the concerns about pre-hospital whole blood is that if paramedics are driving around in San Antonio, they had a private paramedic system. So every paramedic group was a private group. And I think we had 75 different companies in the greater San Antonio region that would bring in patients on their ambulance. I don't actually know who got to do what and how the like turf wars played out, but it was always a different group every time. And the vast majority of them carried whole blood on their truck. And one of the concerns was, well, it's going to go bad. And it turns out that we actually wasted less than 1% of all whole blood, period. All of it across the board, less than 1%. And part of the reason is that whole blood can be cold stored for about 35 days. So we created a system, really they did, and I was a part of it and got to learn from it, where the regional whole blood program had this system whereby on the left side here, air medical personnel, ground EMS providers, some level 4 trauma centers, which were like essentially, what we would consider maybe like University Hospital would probably qualify as a level 4 trauma center. So it's not technically a trauma center from a COT standpoint, but is able to care for a sick patient prior to transfer. They would carry day 1 to 14 blood. So the 2-week-old blood, as soon as they didn't need it, we would send it back to this system and they would then rotate it to the university hospitals or the level 2 and 3 and level 1 trauma centers, where I promise you we will go through it super fast. And this actually resulted in less than 1% of whole blood wasted. And the blood that was wasted, admittedly, was almost entirely due to the trauma team and or anesthesiologist forgetting how long it was out of the fridge when we were going between the trauma bay to the OR 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 to the ICU, etc. So we then learned how to keep a better track of that and prevented that from being even less. We made it even less than 1%. So pre-hospital whole blood and mass casualty events, a very unfortunate situation and around the San Antonio region, as I'm sure many of you are familiar with, that I wanted to highlight of how incredible the pre-hospital system can be in terms of being a part of the greater system and not just the one patient you pick up. So on May 24th, 2022, the Uvalde Robb Elementary School shooting happened. And Uvalde Memorial Hospital, I put a little Google map here where the University Hospital is the level 1 civilian trauma center, and where Uvalde Memorial Hospital is, it's an hour and a half to 2 hour drive, and these are back roads, like very rural Texas. 25 inpatient beds, and this was considered a level 4 trauma center. So at 11:36 a.m. on that day, there was our first report of an active shooter. About 22 minutes later, the South Texas Blood and Tissue Center was notified that the shooting was indeed confirmed, was legitimate. As soon as that happened, within 7 minutes, there was authorization to have 15 units of whole blood and 10 units of basically packed red blood cells shipped to Uvalde Hospital. 4 minutes later, it was packaged for transport. 1 minute later, Uvalde Memorial was confirmed as the destination. 8 minutes later, the blood was on the helipad. And within the next 12 minutes, helicopter touched down, got the blood. 2 minutes later, it was in the air. And ultimately got to Uvalde Memorial Hospital in 67 minutes from the time of the first report of an active shooter. We're not even, or from the notification of the soft tissue blood bank. This is an incredible response time to be able to transport 25 units of blood to a level 4 center to be able to transfuse people who are actively dying of hemorrhage. The other fascinating thing that happened unexpectedly because of what I had just mentioned is that we had a lot of paramedics dispatched to Uvalde, and they actually brought with them another 20 units of whole blood by neighboring EMS units. So within an hour and a half, we had 45 units of blood, the majority of which were whole blood, 35 of them, in Uvalde Memorial Hospital, which is just an incredible amount of product to have available for a mass casualty event like this. And this is honestly all thanks to the pre-hospital personnel. The trauma surgeons were not involved in this. This was already protocolized in the system. And we may have something here similar in Charlotte, but I thought this was an excellent example of the power of the pre-hospital personnel contributing to the greater trauma system. Again, going back to that mantra from there, every second counts in this, and I really cannot emphasize how incredible this response was here. So in the greater Charlotte region, we've got multiple trauma hospitals that all work together, and eventually those paramedics will bring your trauma patient to the trauma bay, and that's where we now are in the uh, in-hospital portion of the trauma. They get dropped off in the trauma bay, and then we do ATLS. But I want to highlight, and part of why I wanted to do this whole talk is that the original intent of the ATLS program was to train doctors who do not manage major trauma on a daily basis. It's been extrapolated and expanded to be any doctor that does trauma. But the reality is that when you're a trauma personnel, EM, anesthesia, nurse, anybody involved at the trauma hospital, we can do far better than ATLS. ATLS was meant for the people at Uvalde Memorial who don't deal with trauma, but on the off chance it comes in, they're all trained enough to do a damn good job of taking care of those patients. But we, as the level 1 to 3 trauma centers, can do even better. And these are some of the points that I think come up frequently, not just at CMC, but it's come up at prior places I've worked at, and lots of kind of areas of debate and not necessarily inefficiencies, but places we could be more efficient. So with no further ado, going to the basics of just kind of highlighting different components of the primary survey and the ATLS trauma evaluation that I believe can be expedited. This is where there's a little bit of my opinion in there, and I will tell you when it is my opinion. And some of it's based on literature, but a lot of this is, again, the stuff that at the end of the shift or at morning sign out amongst us trauma surgeons here and everywhere else I've been, we talk about these things and we ask ourselves, how can we maximize this efficiency for next time? So regarding the airway, um, patients at risk for airway compromise often require definitive airway, which is a tube with a cuff inflated below the vocal cords. Cannot emphasize enough that a definitive airway has a tube with a cuff below the vocal cords. Hypoxia is one of the leading causes of cardiac arrest in trauma. This CT scan is not unfamiliar to the majority of us that have the unfortunate reality of seeing these scans after they get obtained. This is somebody who had massive aspiration. This person is probably looking at, for sure, a prolonged ICU stay, ARDS, probably a tracheostomy, if not ECMO, if they even survive this. And I've unfortunately had this exact scenario happen to my colleague when I was on call, and I've had it happen in other scenarios myself. But aspiration in the CT scanner, because you have an LMA in place, which is not a definitive airway and does not protect your airway from aspiration, with the resultant neurologic hypoxia, ARDS, is worse than a quick attempt at ET tube intubation, even if unsuccessful with the LMA replaced. While the trauma evaluation is going on, taking the LMA out is pretty quick, and taking a look to see if an ET tube can go in, particularly if they're GCS of 3, you don't even need to give any RSI meds most of the time. You can just suction them and place the tubes. I don't want any of my EM and anesthesia colleagues to be like, hey, what's the surgeon talking about? This is ridiculous. We actually managed all of our own airways where I trained. And this was the standard of care. If there was not an ET tube in place, the very first thing we did is we transferred the patient over and we secured their airway with a definitive airway. This will prevent aspiration, which you may not even be acknowledging or recognizing if there's something like an LMA in place. And I'm telling you, trying to intubate the person in the CT scanner after they aspirated with an LMA in place with all the it's for anyone who's done it, you know that it's a disaster and it's usually resulting in a cric. This is based on pure opinion. This is one of those ones that I don't have literature for, but I do feel strongly about because I've seen this happen and I've had people die on me because they aspirated and not because of their actual traumatic injuries. Next, breathing. This is both pre-hospital and in the trauma bay. So tension pneumothorax is a topic that comes up a lot. And this is a real phenomena, particularly now that we have these different kinds of occlusive dressings that are put on pre-hospital. Someone gets shot in the chest. Quite frequently now, I see people putting on these occlusive dressings that I'm drawing a blank on the name of right now, but they're really, really sticky, big see-through dressings. They slap them on and they really seal up that hole, which then turns your open pneumo into a closed pneumo, which is a tension pneumo. This is probably happening a little bit more here for unclear reasons. I don't know if this is pre-hospital training or what it may or may not be, but I've been in places where these needles, this is a decompression needle, They were used like way too much. And I think it's a good tool to have in your tool shed with a caveat. This is a $16 needle that I have seen on many occasions look like this on the CAT scan. And I've actually told my residents or APPs, the team, don't pull them out. Like, let's get a scan. Let's see what we're dealing with, because you get an X-ray, their lungs are totally up, and these needles are in place. And you get the CAT scan and you see this, and you can basically appreciate here that both of these went right into the lungs. Now, this might be because the pre-hospital personnel didn't hear breath sounds when they put it in, or maybe rather than doing a nice, intentional placement, maybe they just kind of jammed them in like you see on the movies with in military shows. But these needles have been on more occasions than not so close to hilar vessels, or maybe even in them, that it terrifies me, which is why I think that instead of $16, we can, and this is $16, like I can buy this today, not using any contract, any kind of anything. This is like literally, you can go online and purchase this. I think for $32, you can get this one called the enhanced pneumothorax needle, which is better because it says the word enhanced in it. But for anybody who does surgery, this is a really awesome needle in that right here at the tip, it's actually a blunt tip that retracts into a sharp needle. So it's the equivalent of a Veris needle. And this needle, you can actually theoretically jam into somebody's chest. And the second it doesn't have resistance, that blunt part shoots out and covers up the sharp part, which then lets you decompress the chest safely. And even if the lung completely re-expands into that needle, it's still a blunt needle. It's not going to cause any parenchymal lacerations. So for $32, I'd rather you use this one on me than the $16 Target one. For circulation, tourniquet use, we've already kind of touched on, but the use a tourniquet only when direct pressure is not effective and the patient's life is threatened. This is from ATLS 10th edition. Again, I think a lot of times we're throwing tourniquets on probably a little too quick, but at the very least, you can always go and reassess it. And again, if you can put a tourniquet on, you're allowed to take it off. Pre-hospital, in the paramedic, in the back of an ambulance, you can take it off at any point in time. At the other hospitals that don't usually land traumas, you can take them off. And if you know how to put one back on, that's fine. Just put it back on in the correct place if you need to. And remember that pressure stops all bleeding, 100% of bleeding. Some of it you can't access from the outside, which is when you need the surgeon to make an incision, but all bleeding stops with pressure. I can verify that myself as a fact. You just need to know where to push and how to get there, if you can reach it. So this is an interesting study that was done looking at an experimental controlled exsanguination model on sheep arteries. So they did a 2.5 millimeter side hole carotid arteriotomy on these sheep, and they just made the hole and left them. And they actually measured how much they bled. So initially they bled about 400 cc's a minute, which is a lot. And when you figure you only have 4 to 5 liters in your body, you're talking like 10 minutes and you're going to bleed out, which is maybe not uncommon for a lot of our patients that have massive vascular injuries. But after 5 minutes, this dropped down to about 100 cc's a minute, less than that actually for the majority of them. And after 17 minutes, this 2.5 millimeter hole in the carotid artery just stopped bleeding. Granted, they lost 60% of their total blood volume, but all of the animals still had a perfusing rhythm and a heartbeat with blood flowing through their body, because as we know, all bleeding stops eventually. And there is the funny adage of that where, yes, all bleeding will stop eventually when the patient's dead, but there's also the reality that a lot of bleeding really does stop on its own. Our body is really skilled in doing that. And as long as we don't do something detrimental to maybe dislodge that clot with a huge bolus of crystalloid, or if we can keep their blood pressure under control, etc., a lot of this bleeding will stop on its own, which is why we don't crash every trauma patient to the OR now that has some, liver laceration if it's not massively exsanguinating, because the bleeding already stopped. Speaking of bleeding and dislodging clots, I just want to touch base on warm fluids versus giving whatever's available, because the patient's hypotensive. Oh, dear God, put something on a pressure bag, which I'm sure at one point in time you've all been there and involved in that. And the provider may have even said, please give a bag of warmed fluids. And you grab a bag out of the warmer and you're like, yeah, it feels good enough. Well, I want to highlight exactly how important warmed fluids are. Your body temperature in theory is about 98.6 degrees Fahrenheit. In reality, a lot of trauma patients are their temperature's low, hypothermic. Warmed fluids are somewhere between 98.6 to 104. So let's say it's even 104 degrees as like the warmest acceptable temperature for warmed fluids to be infused. That's like a really hot tub. 104-degree hot tub, like if you've ever gotten in one, at least for me, that is a very warm hot tub. And it's a 5.4 Fahrenheit difference. And I get in there and I'm like, wow, this is warm. And I start sweating and like my face gets flushed. And now think of a swimming pool that's like 80 degrees Fahrenheit, which is a really nice swimming pool. It's not too cold. You jump in and you're like, yeah, this is really good. You can stand in there for like an hour. Um, Room temperature is usually like 68 to 72. If you got into a pool at 70 degrees, you would be quite cold. That is a chilly dip. And this is what we're giving in terms of our room temperature crystalloids if you grab it. It may not seem that cold to you, but it's 68 to 72 degrees. That's the temperature of the room. Keep in mind, you can microwave crystalloids if you're in an austere environment, although a lot of hospitals do not allow this, but it is a reality. Just make sure you remember to never microwave blood. It will have all sorts of devastating complications to the components within the blood, so don't ever do that. But wanted to highlight the importance of really making sure your fluids are warmed because it is much easier to give somebody less than warm fluid temperatures than it is to give them actually warmed fluid, and that will just hurt their coagulation cascade, the triad of death. Quick mentions on exposure here, just things again I've seen at the majority of places I worked, and at a very few of them have seen this done exceptionally well. Tuck right, roll right. When you go to roll the patient, rather than rolling the patient and then tucking everything and then rolling the patient and pulling everything out, what you can do is you can actually tuck all the clothes into the patient's right side and then roll them onto their right side. And they've effectively rolled off of all of those clothes. So you can pull everything off. X-ray board goes under, and you've already negated the need to do like a full roll the other way. Again, every second counts in the trauma bay. We're talking about seconds when it comes to people's lives in hemorrhagic shock. The next one is X-ray should be available at activation. We have that virtually every time, but that should be the standard for any trauma hospital that lands a trauma. You want to roll the patient as fast as possible. On numerous occasions, I have seen the roll get delayed for labs or for doing a neuro exam, which is important, but it should be an expedited neuro exam on primary. And on their back, they've got this giant laceration that's been bleeding the whole time. You want to actually see them quickly as part of the primary survey and get that part done so you can eliminate any exsanguination. Primary survey should take less than 2 minutes. I've timed it, and my chief residents, prior institutions could do it in about 45 seconds. Here, we've got multiple personnel that can do it that quick too. And the entire time in the trauma bay, our goal, our standard of care was you had to be out of the trauma bay in 10 minutes. If you weren't, your case was reviewed every single time. Every time you were in the trauma bay for more than 10 minutes, it was reviewed. And it was very annoying, but you know what? We really learned to make sure that we made every second count in the trauma bay. Similarly, adjuncts, when you're looking at things like the EFAST, there are parts of the EFAST that I think are great. I think looking for lung sliding while the primary is going on before you can even get the x-ray could be a very helpful thing. If the patient is stable and you're doing the abdominal portion of the FAST, probably not going to change management. So don't let that delay your care. You can still perform it, but don't delay getting to the CT scanner. Same thing with pelvic x-rays. If you don't suspect the patient has an open book pelvic fracture and they're essentially stable, and your next move after that x-ray isn't like, oh yeah, I thought we needed a pelvic binder, you probably don't need the pelvic x-ray if you're already planning on CT scanning their pelvis. Extremity x-rays before the CAT scan. This is a real example of a time when I saw an extremity x-ray being obtained to verify that this individual had a fracture. And I turned around and like my jaw dropped. And I was like, why are we wasting time with this? One, this guy's in a ridiculous amount of pain. But like two, like he has a fracture. I could see it. Like we didn't need an x-ray of it. We can call ortho now. And you're going to need formal x-rays when you get back anyway. All you're doing is wasting precious seconds to get into the scanner to identifying life-threatening injuries. If it will not change management, do not waste time. Every second in trauma counts. And the last one, believe this is the last topic, the highly debated traumatic cardiac arrest. And I put this in there and have the huge caveat of there's not enough data to make a definite recommendation one way or the other. And I am not going to tell you all what to do. Spoiler alert. But just something that we often talk about. I did a little impromptu survey of a bunch of the EM surgery and anesthesia providers, and I thank all of you for your responses, particularly on short notice. But essentially, if you've got an arterial line in place, the question was, at which point during the trauma or non-trauma evaluation, doesn't necessarily have to be trauma, would you start CPR? And I had a bunch of great answers. A lot of people, the majority said, if there's no palpable pulse, we're starting CPR. And that probably is the textbook answer, to be honest. Not that you're all right or wrong, but I think that is completely reasonable and a great thing to teach everybody. Now, if you've got an arterial line in place, you can theoretically use it. If they've got a great waveform, and you can see they've got a dicrotic notch, and the whole everything looks like they're perfusing. At which point do you look at that and just say, I don't care if I can feel a pulse or not. You need CPR. And we had a couple say that the arterial systolic pressure of 30, 40, 50, or 60. We had another person weigh in and say, well, it's not really about the arterial pressure, and it's about the end tidal CO2, which I love that answer, because that was actually one of our metrics. Every single trauma patient that came in had to have at least our highest level activation. There had to be an end tidal CO2 as part of the report. It was highest heart rate, lowest blood pressure, what was the last end tidal CO2, because that tells you how well their heart is perfusing to their lungs to be able to get rid of the CO2. And a couple people said no chest compressions for trauma, which again is great. Someone else also mentioned the diastolic blood pressure of perfusing the coronary arteries, which I think is also a fantastic answer. And again, none of these are necessarily right or wrong, but it shows you there's a lot of variability. I use this example of the Princess and the Pea. For those of you who may not know this story, there was a prince who wanted to marry a princess, and the mom said, well, this one looks like she's not real, or she's not a real princess. Or if she really was a princess, she would notice a pea underneath like 20 mattresses of when she was sleeping at night. And sure enough, the princess noticed it. I think the prince told her, and then, they got married, and sure, it was a happily ever after story by Hans Andersen. But this is a neck where I could basically tell you, looking at it, where her carotid artery is. But the reality is a lot of the trauma patients come in looking like this. And while Jonah Hill now looks nothing like this and is quite athletic and muscular, you can imagine that trying to ask anyone to palpate a pulse on this individual is going to have a different result, at which point they cannot feel the pulse, than the female neck that I just showed you before. You're going to start chest compressions if you go purely by no pulse on Jonah Hill before you will on the other person, purely because you can't physically feel the pee underneath all of those mattresses, so to speak. This here may be the future of blood pressure measurement. This is using ultrasound rather than all these other devices. And you're basically putting a probe on the neck and using a bunch of math that I don't entirely understand. They're able to actually almost entirely one-to-one estimate the blood pressure so that all of that subcutaneous tissue will become less relevant. It's not here today and now, but it's certainly in our future. And just quickly, I know we're running a little short on time here. Causes of traumatic cardiac arrest, just to briefly review here, going into the resuscitative thoracotomy concept. These are the most common causes of traumatic arrest, and there's not really an order of these, but hemorrhagic shock is probably the most common, although I couldn't really find great literature to support that. Hypoxic arrest is for sure a thing, tension pneumothorax, cardiac tamponade, and all the other reasons people go into cardiac arrest before their trauma, like regular heart attacks. And I don't want to, downplay that, but those are real things that happen prior to car crashes and other traumas. So the question is, for which of these underlying causes will CPR help? And when you look at this list, like tension pneumothorax, definitely not. Cardiac tamponade, definitely not. If the heart can't pump through it, you're not going to be able to pump through it. The pre-hospital traumatic arrest, absolutely. If you're thinking this person is having a cardiac event, by all means, this might help. Hypoxic. Well, so now you're talking about a heart that's full of blood that just stopped beating because it has no oxygen. And in that case, yeah, you know what? You could do CPR and get their heart to beat and get blood perfusing through their body, but the blood has no oxygen. That's why they're coding. So until you actually intubate them, the chest compressions are irrelevant. So if you can't intubate them, get end tidal CO2, and then actually exchange oxygen, then you start heart chest compressions. And then in that case, yeah, you can probably do it, but you need that definitive airway and to make sure that you're actually oxygenating them before the CPR will help. And then hemorrhagic shock is kind of fascinating because when you think about what you're trying to accomplish in CPR is you're trying to augment or recreate cardiac output, which is stroke volume times heart rate. In an optimal scenario, we're talking like best case scenario, non-trauma, non-hemorrhage, like healthy person, the best you can possibly do is recreate about 20 to 30% of normal cardiac output. Now imagine you've lost about 50% of your blood. Your cardiac output during CPR is, I don't know, 10%, 15%, like at best. And this is like best case scenario. And keep in mind, every time you pump that hard across their lacerated kidney, you're probably also losing more blood. So each pump is going to be less efficient than the last. The key is resuscitation, as I mentioned earlier, and we'll keep mentioning. And the timing is valuable, is invaluable in terms of how fast that gets into them. Quick notes on resuscitative thoracotomy, and then we'll be all done. Per ATLS, the American College of Surgeons, a committee on trauma, it is mandatory to have an operating room with a surgeon present prior to performing a resuscitative thoracotomy. This is because after the resuscitative thoracotomy, you have to get to the operating room in order to release the aortic cross clamp. You need to be able to, this was our metric of standard of care, is that from the time the decision is made to do a thoracotomy, the aorta needs to be cross-clamped within 60 seconds. That's not based on literature. That's not based on fact. That's not based on data. That's just how I was trained. If you do not feel comfortable that you can get an aortic cross-clamp on in 60 seconds, and at the same time, don't get the esophagus, which the OG tube will help with, and be able to physically see, which you basically never can, for which having a definitive airway main stemmed into the right bronchus can help by deflating the left lung a little bit. You shouldn't be performing the resuscitative thoracotomy because during that procedure, you will stop chest compressions. Your cardiac output will drop to 0 during your thoracotomy, which means normally we would say you have 10 seconds to do a pulse check and then you restart your CPR. So saying that I'm giving you 60 seconds to cross clamp the aorta and then open the heart and start internal cardiac massage is theoretically a long time, but admittedly it does take a minute to get to the aorta. The other reason that you need to be in a place with a surgeon present with an operating room is the aorta can only really be cross-clamped for 30 minutes. Otherwise, you're going to have a warm ischemia time of the small bowel that will render the patient probably non-survivable. Anyway, when you release that, the amount of lactic acid that'll flush back into their system is way too much. That aortic cross-clamp needs to be transitioned to an infrarenal cross-clamp. Or just suprarenal, but otherwise, this is part of the reason you need to be in a center that can actually manage this afterwards. And when you do an internal cardiac massage, one of my favorite parts about it is teaching everybody to do the baby shark maneuver. When your hand is on the heart, the heel of your palms needs to stay together, and you do it like this, like a baby shark. The reason for that is that if you push first here, you will rupture the ventricle, the left ventricle. And I have seen people die of blunt trauma, and the medical examiners or the autopsy report said, basically devastating liver injury, devastating spleen injury. And despite the fact that there was no blood on entry into the pericardium when we opened it, there was a rupture of the left ventricle that was suspected to be the leading cause of death in this individual. And obviously that was just iatrogenic. But important to remember, and I always think it's cute to teach everybody during a very stressful moment to do baby shark on the heart in the trauma bay. That's all I have. I will take any and all questions. Thanks so much for hanging out with me for an hour.
Dr. that was great. A tour de force through all things trauma before and after ATLS. So I'll open up for questions. There is one in the chat that says, does that include response time? I know that was early on in the talk, and that might need some clarification if you're still with us. Other than that, any questions from the audience? A lot of little clappy baby shark hands going up in the ether sphere. Here, I'll ask you one just to get things going here. What do you think about the concept of the walking blood bank in a community? You did a lot about blood transfusion and whole blood, and especially with the discussion in Texas, but any thoughts on that?
I don't know if you set me up for this on purpose or not, or if you're aware that I've published on this exact topic of the walking blood bank in Texas. But one of my most recent publications.
You're not supposed to play all your cards here, Dr. Cirone.
No, but in all seriousness, I'm actually quite knowledgeable on this topic. So we have the civilian walking blood bank in San Antonio now, and it is a fascinating concept whereby individuals who donate blood are pre-screened ahead of time to be low titer O positive whole blood donors, and they are actually asked to not donate blood. and they are asked to go live your life in community, and they might rotate them to get a unit every now and then, but there's a whole swath of people that are now referred to as, they were referred to as the brothers in arms, and we actually now include females in that, which is a very new thing. So now that group is called the heroes in arms. And during a mass casualty, we will call four of the people in this group per victim shot or injured to come in and donate blood. And on the spot, they will donate their blood. The blood is rapidly tested for communicable diseases and other things, but it is essentially presumed that that blood is free of HIV, hepatitis C, etc., and it is immediately transfused into the other individual. A small portion of it is then kept and tested for all these other conditions. And if at any point in time during the program, when they send out surveys, if you're like, hey, I've got, multiple sexual partners, or I got a tattoo or other high risk activities, then you get removed from that portion of the program. Then you're put in the regular blood donation program. That, to my knowledge, has not yet been massively activated in San Antonio, but we have something like 3,500 or 4,000 individuals signed up for that program that we can activate at any point in time. The theory being, if you call four people to donate blood, one of them is actually not working, available to literally drive and donate blood. And we have a mobile blood donation, like a mobile home, or like a trailer home that actually goes to the scene of the trauma, where you would drive to that scene and donate blood on the scene just outside of, the ground zero, so to speak. So it's a fascinating program. I'm a huge believer in it because that is the pinnacle of being prepared for the worst, which you can never be too prepared.
Great answer from a true expert in the field. Other comments, questions?
Yeah, so since Justin likes softballs, you talked a lot about the low titer O positive whole blood. What do you know about, because I already know you know about, the use of this in pregnancy age females?
Sure. So that came up as a very hotly debated topic in the beginning of low titer O positive whole blood transfusion in the San Antonio region and across the country. It turns out that it's actually really not a problem at all. They basically looked at the rates of a female showing up that needs whole blood transfused emergently is already incredibly low of childbearing age. Then when you multiply that by the rate of females who are of childbearing age that are O negative, it is also exceedingly low. Now you have to identify the people that are not only O negative, but actually Rh negative with no anti-D, meaning they haven't been exposed to the positive Rh factor in the past to begin with. So now you finally identified this very small portion of the population that are females who are O negative, that are Rh negative, and don't have the antibodies to it, and you give them a unit of low titer O positive whole blood. There's now an even smaller percentage of them that will actually form antibodies to it. You don't automatically create those antibodies. And now that individual needs to go on and then find an Rh positive partner, and then have a 50-50 chance of having an O negative child, and then have that O negative child exposed to the mother's antibodies that she had maybe during an accident or maybe during some kind of placental issue. It turns out that at the end of the day, you're going to have to if you said absolutely not, we will not do whole blood transfusion or any transfusion that's not O negative, you would end up letting about 500 women of childbearing age die, or at least not get massively transfused, to save one potential fetus from having a transfusion reaction. And it would take, I think, if I remember correctly, it was 800 years, at least for San Antonio. Yeah, Dr. Gibbs, I see your hand up.
Yes, sir. Great talk. Really enjoyed it. I have one perhaps modified opinion on something you said about bedside testing in the trauma room. And I was always trained to make sure that you don't leapfrog over imaging before you leave, because you don't want to discover a tension pneumothorax or an open book pelvis in the CT scanner. So how about this? I would say I have found that most days of the week, getting your fast done and just having an abbreviated set of x-rays and blunt trauma of the pelvis and chest, that doing that most days of the week is going to be better than waiting to get the information in the scanner. So I agree completely with your emphatic message about reducing time in the trauma room, but I also worry about discovering things in the CT scanner 15 minutes from now that you sure wish you knew before you left. And anyway, so it's a general comment, maybe a slightly different way of saying the same thing, but I'll be interested in your thoughts on that.
No, and I think the important part there, so the chest X-ray is 100% necessary. I've never let a trauma patient off from scene leave the trauma bay without a chest X-ray. That's 100% of the time. And there's a great talk we can have about the use of EFAST, the lung sliding, rather than chest X-ray to evaluate for that. But the pelvis X-ray is one that we had debated a lot in my prior institution, because if somebody's pelvis was stable, they had no pelvic pain, and they were reliable, getting that pelvic X-ray is unlikely to result in you needing to put a binder on for hemodynamically unstable open book pelvic fracture. That was the thought behind it. Now take a different population that comes in GCS 13, you give them a whole bunch of pain meds, maybe they're not quite with it. Now you're talking about a group of people that I would image for that exact reason, that you don't want to miss something and then discover in the CT scanner, which is the worst place to discover pretty much anything other than your CT images.
Yeah, and that what you just said, I agree with completely. And if you look at the literature on clinically clearing the pelvis in trauma patients, what I understand of that literature, exactly like you said. So alert, not intoxicated, following commands, no external evidence of pelvic trauma. Then the pre-test probability or the post-test probability of a pelvic fracture is really remote. But I want to make sure that we don't leapfrog over that in the drunk, unconscious person who ends up having big trouble down the road. That's all.
Completely agree.
That's the only point. But again, most importantly, I agree with your first comment, which is don't waste time in the trauma room.
Great
And great
comments
talk.
and questions. About out of time. But anybody else have it's a great discussion. So if there are any other questions, we can probably squeeze one in. I think the chat's wrapped up. All right, not seeing any. Dr. Cirone, thanks so much for sharing your expertise with us. There are a couple of comments in the chat about some education at other hospitals. So if any of this you think it would be useful wherever you might be, please just shoot Scott an email. And from an MTAC perspective, we'd be happy to look into whatever we can share, whatever community you're in, whether it's Stop the Bleed, ATLS, Rural Trauma Team Development, you name it. So please let us know and we'll see what we can put together. Justin, thanks again for your time, and thanks everybody for joining us. Great talk, very informative. So everybody have a good rest of the day.